Today I want to talk about suprasellar masses, partly because we've had a number of them of late that have been of considerable interest. So I think it's an appropriate point in time to discuss them. Now, whenever I see lists like this myself, I sort of, it's like a high-pitched noise goes off in my head and I can't seem to remember them. But I think by seeing them and maybe putting them into some context, it will help you. Obviously, the history is important. For example, if the patient has a history of neurofibromatosis type 1, you should be thinking about an optic nerve glioma. If the patient has long-standing seizures and a specific type of seizure called gelastic seizures, you'll be thinking about a hypothalamic hamartoma. But frequently, the only history we have will be of headache or vision changes. And so among this list, the most common that you will see will be craniopharyngioma and Rathke's cleft cyst. But I always want you to keep aneurysms in mind because it's essential that we do not mistake these for solid tumors. So let's start with this patient. This is a 17-year-old who has vision changes and headache. And so as we look at the scan, the first thing I want you to recognize is that we can see the normal pituitary here at the bottom of the tumor. Once we've seen a separate pituitary gland, you can put to one side the notion that you're looking at a pituitary adenoma. And now we're going to start to think about other tumors that arise in the suprasellar space. So in this region, in a normal patient, we know we're going to have the infundibulum, we'll have the optic chiasm, the third ventricle. And so here we look on the T2 weighted scan, we can see the substantial mass effect that's effacing the third ventricle. After administration of contrast, the mass enhances. We should be thinking in this young patient of the possibility of a craniopharyngioma. A CT scan was obtained. Ordinarily, we don't think about necessarily going to CT when we already have the MR scan, but it does provide an important piece of information that there are multiple calcifications, and this represents a typical craniopharyngioma. So again, in the pediatric population, calcifications are very common. Probably 85% of craniopharyngiomas are calcified. And so with this complex suprasellar mass that again is separate from the pituitary gland, will lead with that diagnosis, and that would be the correct diagnosis. Here's a different patient, but sort of same construct, suprasellar mass, you can see here, separate from the pituitary gland. There is enhancement. If you're going to call it a craniopharyngioma, it should be enhancing, could be just a nodule, but there should be some enhancement. And the CT scan shows considerable calcification of the tumor. These are difficult tumors to resect because they have from what I understand, a sticky quality where they become adherent to the structures in that area, including the carotid arteries. So challenging operation for the surgeons. Now here's a suprasellar mass in a 52-year-old patient. And what I want you to recognize is, again, that we see the separate pituitary gland here. We see the mass, which lies here anterior to the mammillary body, and in the region of the third ventricle, the infundibulum is going to be here. Here we can see this mass, which lies here behind the carotid artery in front of the mammillary bodies. And here on the post-contrast image, again, normal pituitary gland, here is the suprasellar mass. So the things we'll consider will be an optic glioma and a craniopharyngioma in this patient. Now, how can we tell the difference? Well, I mentioned the patient's 52 years of age, and calcification is much less common in this population with craniopharyngiomas. If you see small cystic structures that have T1 shortening, even in an adult, you should favor craniopharyngioma. But in this case, this proved to be an optic glioma. Here's a 30-year-old patient with known neurofibromatosis type 1. Here again, suprasellar mass, separate pituitary gland. Here you see the mass sort of extending up between the carotid arteries. You should not even consider the diagnosis of a pituitary tumor, like a macroadenoma, even though it has this so-called waste appearance here on the coronal imaging, because again, we see this separate pituitary gland. This mass is enhancing. This proved to be a pilocytic astrocytoma, which is the most common variety of optic nerve tumor in NF1 cases. Now, this is probably the most common thing I see in my practice will be these small cystic structures, even either in the pituitary gland or separate from the pituitary gland with T1 shortening. And this is most likely a Rathke's cleft cyst. Now, here's a different case. Here you see a mass sitting separate from the pituitary gland in the suprasellar region. A little bit of complex signal here, but it has this unusual quality of short T1 and short T2 relaxation time. And to me and to you, it should remind you of a colloid cyst, which of course occurs in this region in the anterior superior third ventricle. But I think it's the same concept that this is a viscous, highly proteinaceous, perhaps hemorrhagic mass. These will show no evidence of enhancement, although you can see why it might be hard to be sure since it's intrinsically bright on the T1 weighted imaging. This is a much larger Rathke's cleft cyst, and these can become really quite large. So keep Rathke's cleft cyst in mind, particularly when you see this property of T1 shortening and short T2 relaxation time. Now, this was an unusual patient, but here we see there's a suprasellar mass with subarachnoid blood. And there were other slices here I'm not showing you, but the patient had presented with symptoms suggestive of subarachnoid hemorrhage. She went on and had an MR, she went on to have a CTA that it showed that it didn't have the typical appearance of an aneurysm in that it should have enhanced at least comparable to the carotid artery in this frame. Patient went on and had an MR scan and had this appearance. Here you see this rounded lesion, homogeneous T1 shortening, separate from the pituitary gland. And you'll notice on the T2 weighted scan, it's relatively dark with a darker area associated with it. This is a so-called nodule. Apparently at surgery, it reminds, I guess, sort of, I can think about it as like a lump of like wax, candle wax inside a cyst. And so this combination of findings, homogeneous T1 shortening, dark on T2 with a nodule within it, these are typical features for a Rathke's cleft cyst. The patient went to surgery. This was proven at surgery. So this is what's called apoplexy of a Rathke's cleft cyst. So we think about apoplexy being associated with pituitary tumors, but you can also see that with Rathke's cleft cyst. 2 years after surgery, we actually see recurrence of the Rathke's cyst, again, separate from the pituitary gland. So again, I've shown you craniopharyngiomas, some typical craniopharyngiomas, typical Rathke's cyst, and here an atypical Rathke's cleft cyst. But at some point, you're going to find that they're difficult to distinguish. And if you look in the pathology literature, there actually probably is a continuum between Rathke's cleft cyst and craniopharyngioma. This is a case of a 9-year-old non-contrast skin gadolinium scan. Here again, we see a suprasellar mass. The patient presents with symptoms of diabetes insipidus. You don't see posterior pituitary gland. The presence of an enhancing suprasellar mass in a child with absence of the posterior pituitary should make you think about a germinoma, which this proved to be. So germinomas, for some reason, are associated with disruption of the communication between the hypothalamus and the pituitary, and they may develop diabetes insipidus. In fact, patients with diabetes insipidus, you should be thinking of an infundibular lesion. And again, in this age group, germinoma is a reasonable consideration. Now, this patient also has a germinoma, but you'll notice there's abnormal kind of irregular enhancement of the region of the pineal gland. And you'll also see some enhancement here in the region of the corpus callosum, sort of subependymal, you see up here. So this multifocal involvement also favors a germinoma. So keep that in mind, especially when you see this kind of irregular enhancement associated with DI in the suprasellar region. Here's a 6-year-old with precocious puberty and seizures, large suprasellar mass separate from the pituitary gland. You'll notice that it resembles the brain on the T1 weighted scan and resembles the brain on the T2 weighted scan. I'm not showing you the enhanced study, but it doesn't show any abnormal enhancement. This is the typical appearance of a hypothalamic hamartoma. These are difficult to treat, but it's important to establish the diagnosis. This happens to be a particularly large one, but something to keep in mind, again, in the suprasellar region. Here's a 46-year-old with headaches. I see an enhancing mass in the suprasellar region, separate from the pituitary gland. So I'm not considering a pituitary adenoma for this because of this cleft between them. The optic chiasm is draped across it. I'm a little worried about the homogeneous intense enhancement, so I'm going to go on and pursue this because I'm worried that this represents something besides the usual craniopharyngioma optic glioma. Here's post-contrast CT, a little worrisome. The patient went on to angiogram. This proved to be a giant aneurysm. So again, I hope you were at least considering the possibility of an aneurysm here, since that's in the differential. Make sure before you send any surgeon in on a suprasellar mass that you're as sure as you can possibly be that you're not looking at an aneurysm. And if you have any question, consider MRA, CTA, and if necessary, DSA. So I've gone over, again, these suprasellar masses. Even though it looks like a big shopping list, I think you should confine yourself to sort of the high likelihood area. In adults, you're going to be craniopharyngiomas. Again, these are not just pediatric tumors. You can see them adults. Rathke's cyst, optic glioma, less common are germinoma, much less common are hamartomas. Don't forget aneurysms in the differential. So I think that's all I have to cover today. I hope you're going to find that helpful in your practice.